you for inviting me. It's always a pleasure to come up to Glasgow, where I've been many a time. Yes, I'm the sort of the clinical lead, the medical lead, if you like, in the trial in terms of organising it, and we've done all these different trials before, and this is the final sort of big systematic trial of therapies that we need to do in Parkinson's disease. So huge thank you, not just to everybody who's organised today, but to all of you for taking part in the trial and developing a research interest into Parkinson's disease. Obviously crucial questions. Now, I think it was really Gillian here who sort of suggested that when you're actually sitting there with patients, particularly doing LSVT for hours on end, and maybe they're having a bit of a break, and they start to say, well, actually, I've been suffering this. And you think, hang on, what's that? Is it anything to do with the Parkinson's? Do they go to the GP, whatever? So very often what they're talking about, because it's nothing to do with the motor features of Parkinson's disease that you've all been trained in, so it's nothing to do with tremor, stiffness, slowness, or speech problems or swallowing problems, which you know all about and are all motor. It's something completely separate. It's one of the non-motor features of Parkinson's disease. Now, the key message to get across is if you do flag up something like this, the next question to the patient is, have you told your clinician, your hospital doctor about this, or your Parkinson's disease nurse? And if they haven't, obviously get them to do that. So we're not suggesting you're meant to manage all of this. You're not necessarily meant to diagnose it, but this might just help you to flag something up to the patient to tell their clinician. And obviously if it's something that sounds pretty serious and they haven't told them before, they might need to bring their appointment forwards and things like that. So that's really all you need to do. But it would be useful, I think, if we just quickly whip through all of the main non-motor features of Parkinson's disease. Now, there are more than I've got time to go through here in about half an hour now. I'm going to focus really more on the mental health side of things because they're by far the most common ones. A little bit more then on autonomic features, which are also common, sleep disturbance, and right at the end, a small amount on pain. There's a lot of sort of pain caused by the motor features of Parkinson's disease because the arm doesn't move. Frozen shoulder is incredibly common. They're an elderly population very often, so they've got comorbid arthritis, osteoarthritis. We're not so much talking about that. We're talking about something unique to Parkinson's disease, central pain, so a little bit about that. So something on each of those really to give you a flavour, and obviously starting with the mental health side of things. And with anxiety and depression, which is obviously a huge problem out in the general population, but there does seem to be something unique in Parkinson's disease, and it's perhaps because patients don't just lose the dopamine in the brain, they lose the serotonin and noradrenaline, the other two catecholamines as they're called. And when you lose your noradrenaline and you lose your serotonin, you get things like depression. And you can do that in experimental models and things like that. And by obviously reversing that chemical process, you can reverse those symptoms. And of course, that's how we treat depression. So very common in Parkinson's disease, and it's not always just a reaction to receiving the diagnosis. Sometimes it is. People just have the shock of the diagnosis, particularly younger patients, and they need counselling and support with that. It's something unique that can crop up at any time during the course of somebody's life with Parkinson's. They've previously been incredibly emotionally robust, but since the diagnosis, not as a reaction to it, they've gradually just got more and more anxious, more withdrawn, don't go out, get a bit agoraphobic, and then the mood can start to crash, particularly as the winter comes on. And the other fascinating thing about this, which you might not be aware of, but depression is one of the non-motor symptoms of Parkinson's that can precede the motor symptoms by years. And it's said that somebody developing a first depressive episode in midlife, the odds ratio for developing Parkinson's is some increase threefold. So the 4 things that patients can get before the motor symptoms are depression, constipation, REM sleep behaviour disorder, which I'll talk about more later. And one thing I'm not talking about today is hyposmia, reduction or absence of sense of smell. And if you've got all 4 of those, then yes, there are people who are starting screening programs for people like that, just as we perhaps are developing treatments for the disease that will actually modify the course of the disease, that will perhaps protect dying neurons. If we can do that, then we need to diagnose the condition as soon as possible. So that's the reason people are looking at screening programs in people with depression, constipation, REM sleep behaviour disorder and hyposmia, loss of sense of smell. Pizza. People can't smell pizza. Nobody knows why, but that's the first thing to go. Coming back to depression, so it's incredibly common. It's said to be anxiety, something like 40% of patients with Parkinson's at any one time in your clinic, and depression, again, it's about that 40% figure at any one time, and very often those two will overlap. So it's important for us to screen for it, but it may be notified to you, and very often it's the spouse that will actually start to volunteer information like that. Okay, that's anxiety and depression. Psychosis. Now psychosis, or an acute confusional state as you might prefer to term it, is basically confusion, but then in Parkinson's disease they tend to have illusions of presence. There's somebody in the room, there's somebody just around, over their shoulder, there's a feeling that there's somebody there with them when there isn't. That can move on into frank visual hallucinations, so they actually see people, they see animals, the little rabbits on the top of the wardrobe, a deceased member of the family, a deceased pet, things like this, and they'll very often volunteer that. And delusions, not so common. That's where people have an abnormal fixed belief, and not too common, I must admit. It can happen to anybody, but if we give them too much medication, that will very often trigger it off. And it's much more likely in older and cognitively impaired patients. So these are the patients who are starting to dement and older. So really, if I've got people in clinic, broadly speaking, over 70, 75, they're starting to have significant memory problems, maybe can't remember all of their tablets. If I start to give them complicated, fancy medication other than levodopa, anything other than levodopa, and I'll trigger off a psychotic state, and the next thing you know, you see them admitted to hospital because of that confusional state. Dreadful for carers trying to deal with anything like this. And much more likely if people are depressed. Visual impairment, of course, will contribute to all of this. And intercurrent illnesses will often trigger it off. Urinary tract infections, chest infections are the common things. So that's a psychotic state, very often in reaction to medication or infection. Probably less likely for you to come across that in clinic. Now, impulse control behaviours are very unusual things which have really happened since we started to use the dopamine agonist drugs. So the agonists mimic the effect of dopamine in the brain at the same receptors, but probably also a different population of dopamine receptors which trigger off reactions like this. Pathological gambling. People can lose tens of thousands of pounds. It's in the press at the moment for ordinary people gambling a lot now. It's so easy to do, but dopamine agonists are involved with the reward mechanism, and so they get this reaction of gambling. Hypersexuality. Punding is strange collecting and categorizing behaviors. They start to collect buttons and spend all night long categorizing them into different categories, and then redoing it the next night. That type of purposeless action, that's punding. Pathological shopping always raises an eyebrow if it's a female patient, really, because the husband usually says, well, they were like this beforehand, so is it really pathological? So overeating, middle of the night, raiding the fridge. They never used to do it. They're piling on the weight. So these are all sort of impulses that they can't rein in. And if you look at it, it used to be about 14%. There was one massive study in the States, 3,000 patients, and it was felt to be about 14% of patients. That's probably come down because we've reduced our usage of dopamine agonists since then. So these are add-on drugs to levodopa. We always start patients on levodopa, but then they can be added later on, and we're tending to use them less and less. So those are these weird impulse control behaviours, and certainly if they mention anything like that to you, then don't think this is nothing to do with their Parkinson's. It is, and it's to do with their medication. That needs to be flagged up fairly urgently, really, because they may tell you and nobody else. The trouble is when we start to take them off dopamine agonists, they can develop what's been referred to as the dopamine agonist withdrawal syndrome, or DAWS, and so they get quite anxious, they get depressed, sweating, cravings. In other words, it's sort of like an anxiety type reaction with depression mixed in with all of this. And it might be something to do with the dopamine agonists. Actually, in fact, one of them, they trialled it for depression. In fact, they're trialling it yet again for intractable depression. And I'm on the data monitoring committee, so it's still going on, all of this. So if you obviously take them off something which is an antidepressant, they're going to get more depressed. So some of this is just pharmacological, chemical, if you like, rather than anything particularly unique. But it really is a devil managing this, and sometimes all you can do is put them back onto a tiny dose of the dopamine agonist. Right. Next in the mental health things is mild cognitive impairment. Now, you might have come across this in Alzheimer's disease as well. It happens in both. And this is basically, they start to develop mild early confusion, loss of memory, loss of short-term memory. They get quite drowsy. Now, that's quite peculiar to this mild MCI, as it's often called. So patients start to drop to sleep. Now, true enough, they can drop to sleep an hour or so after their medication as a sort of peak dose effect of the medication. But if they're dropping off to sleep any time during the day, a lot, and they never used to do that, that's one of those alarm bells in my mind. And certainly if they start seeing things or anything like that, then they've got mild cognitive impairment, and they're very likely to move on to dementia. It's much more common if they're older, so roughly older, over than 70. And these things that have been looked at to try and select which patients are going to progress to dementia, it's the older ones. Semantic fluency, so you know all about that probably. How many animals can you name in 20 seconds? That type of thing. That's reduced. The pentagons at the bottom of a mini mental state, there's those little pictures, two pentagons intersecting, and they're particularly bad at that. And the tau haplotype, that's a genetic test, so no need to worry about that. But there's a high likelihood with these things that people with MCI will progress to dementia. So it's something we watch out for and make sure we've spotted it, so we don't give them too much medication, which might trigger off a more severe reaction. So we're sort of slowly moving on into dementia here. So I've mentioned drowsiness, poor concentration, cognitive decline, can't remember their medication accurately. That's a little bit of a turning point. The carer has to start taking over medication. Then they get the visual hallucinations, and then they can get psychotic episodes and with those delusions. Now, If this is all very, very mild, then, you know, patients might be fine. You don't really need to do too much about it. But if it starts to become intrusive, then there are some drugs we can give patients in this situation. You need to get their mental health team involved, etc. But really, if you pick up things like this, you need to get the patient, as I said, to flag it up to the hospital team. Cognitive symptoms, I don't think we need to go into this in much more detail, but they're quite bad at clock drawing as well. That's the doctor, it's not a great version, is it? But this is the patient, really completely hopeless at making it 10 past 10 or 6 o'clock here. So it's a different patient. So so the main risk factors, as I was saying, they've got PD, they're in their 70s. There's a lot of talk about separating different types of Parkinson's disease, and the more recent work that's been done suggests there might actually be 4 different types of Parkinson's. But for a while we've tended to sort of realise that people who have a lot of tremor tend to do well with their Parkinson's disease. They progress more slowly and don't develop dementia quite so quickly. Whereas those with the postural instability gait disorder type, in other words, their balance goes early on during the course of the disease and really much quicker than you're expecting. You know, within a few years they're starting to fall, which is very unusual. So they're progressing quite rapidly. They've less tremor. It's more to do with their balance. They do very badly. They dement very quickly. One of the minibus drivers in our hospital between the 2 sites came to see me. He was like that, and he progressed within about 3 years to dementia. And it's really sad to see, and horrific, obviously, for his poor wife trying to deal with it all. So that's the dementia side of things. Depression is another risk factor for it. The REM sleep behaviour disorder. Again, I'm coming back to that a little bit later on. There are other general risk factors for dementia, and I'm meaning their cerebrovascular disease. So if they've got stroke risk factors, that's a bad sign in terms of developing dementia. And again, there's genetics behind all of this as well that people are starting to look into. And in terms of the frequency, this is some of our own unpublished data from the PD Med trial. If you get out to 14 years, it's around about 55%. So by 14 years, about half of them will have demented. Half of all of those patients with Parkinson's disease. Now, of course, if they're demented, then that's screened out before you ever see them from the PD COMM trial point of view. So you really probably aren't going to get to see that group, because working with them is probably going to be very difficult. So you may end up seeing a few of them, or people may start to dement during the course of treatment. So definitely, I mean, to be honest, from my point of view, the dementia side of things is the most difficult thing I have to treat. And the pathology, it's all still down to the Lewy body pathology. This is this little red inclusion body, the Lewy body in a dopamine cell, but they do spread to the rest of the brain, and that's where the more cortical problems start to develop, and they develop the dementia. So it's all part of the same pathological process. Now, so that's just about ending me talking about the mental health side of Parkinson's disease, but there's one of my colleagues from the Cambridge area who talks at one of the training programs I co-run for neurologists and geriatricians about Parkinson's disease, and he calls Parkinson's disease a psychiatric condition with an interesting motor phenotype. So it's frankly more a psychiatric condition than it is a motor condition these days. And since we've got reasonable treatments for the motor side of things up to a certain point, i.e. where they start to lose their balance, then, you know, we do quite well with that. But whilst we're doing all of that and doing quite well, we've got all of these other things to deal with, particularly the mental health problems. And unfortunately, as soon as they start to lose their balance, that's about the same time they start to dement. So you get this double whammy of dealing with both things at the same time. Okay. Right, let's move on to autonomic problems. Now, low blood pressure or static hypotension. Now, this isn't just when they stand up, they feel a little bit lightheaded and dizzy. It doesn't always come on straight away. And if you're going to measure their blood pressure, don't just measure it as soon as people stand from a lying position. You need to wait 3 to 5 minutes. And sometimes it's only when they're walking off and they've been standing for a while that the blood pressure crashes, and the risk is that they faint. And if they faint, they can fall and they can fracture. And that's the real worry about all of this, aside from the obvious fact that they're feeling dizzy. Other manifestations, strange things, headache, because the brain's presumably hypoperfused, and this odd ache over the shoulders in the sort of where a coat hanger would be, at the back of the shoulder area there. They get this weird aching sort of sensation. Get rid of the low blood pressure and that can go away. So it's a peculiar phenomenon. Worse after food, because obviously blood is diverted to the gut after you've eaten, and so you have less available systemically. And obviously the key thing here is so many people are on tablets for blood pressure these days. The main thing is reduce their blood pressure tablets, and that will very often reduce the problem. True enough, all of the treatments that we use, dopaminergic therapies, will drop blood pressure. But if they're on antihypertensives, then the thing to do is cut the antihypertensives down. And other things like amantadine. So all the things we use, we have to warn patients, particularly if they're on antihypertensives. Very common problem, sort of again around that 40% mark in most studies. Now, constipation, if you follow patients for long enough, virtually everybody with Parkinson's will have constipation. It's a really common problem, and because of that, if they're constipated, then the levodopa doesn't get absorbed properly because everything gets backed up in the gut, and so as a result of that, their Parkinson's disease control goes haywire from the motor point of view. So not to mention the actual symptoms from the constipation itself. So very common problem, definitely needs to be treated, as I say, virtually universal. Delayed gastric emptying, again another very, very common problem, and because the pills aren't getting out of the stomach, then the switching on, particularly in the morning, can be very delayed, and sometimes they just don't switch on at all. So, and again, there can be symptoms from that as well. So these things are all worth flagging up so that we can do something about it. Domperidone, things like that are used. Drooling is thought now to be because of poor swallow. Now, and I'm not dealing with that because it's a motor feature really and something you know a lot about. But I've put this in here. Most of all of that you really probably know, I suspect, already, but I've left that in because there's a temptation to start using anticholinergic drugs, things like hyoscine, atropine drops, hyoscine patches, things like that. They cause patients with Parkinson's disease to have a psychotic reaction in a very high proportion. Do not do it. Simple as that. Don't do it. And I have to sort of send messages to our Parkinson's nurses who do just want to do something because it's such a problem. But really, that's the key message. Don't use things like that. There are newer drugs coming through for this, which can be used, or botulinum toxin injections into the salivary gland. Bit of a sledgehammer, but it is very effective. But there are things we can try, but you've got to be careful in what is tried. Bladder problems. Now, the problem is bladder problems are very common in the population out there anyway. So any bladder problem, really, it's straight back to the GP to see a urologist to have proper urodynamic tests done. and then they will decide if they're male. Very often it's prostate problems which are treatable, etc. So all of that needs to be dealt with first, but at the end of the day they've excluded all of that. It can still be nocturia, urgency and even incontinence because of the Parkinson's disease, but late in the course of the condition. It's not such a big issue really as many of these other non-motor features. And yes, there can be relief with things like anticholinergics that the urologists use, but they can cause confusion and low blood pressure and things like that. So again, it becomes something of a nightmare to treat these patients later on because of these non-motor problems. Right, let's move on to sleep. Now, the two key things I want to talk about here are restless legs syndrome and REM sleep behaviour disorder. So RLS, restless legs syndrome, these patients it's definitely associated with Parkinson's disease. It can happen without Parkinson's, very common in the normal population, if you like, out there, but also even more common with Parkinson's. And they get this strange desire to move their legs. And they get a funny burning, itching, crawling, tension feeling in their legs. It's very difficult for people to describe this. It's just a feeling. And when they move their legs, that feeling, that unpleasant feeling goes away. So once you've come across it a few times, it's fairly straightforward. And there's this diurnal pattern. It's worse at night. And sort of sitting, watching the TV in the evenings, their legs start to go. And it's even worse when they go to bed, so they can't get to sleep. And so it can cause major problems, really. But it does respond to taking dopamine agonist drugs, if they can tolerate those. Around about 6 o'clock, evening mealtime, works very effective at very low doses, much lower doses than we normally use in Parkinson's. Again, for reasons we don't really fully understand. But eminently treatable restless legs syndrome. Now you may have come across that, but you possibly haven't come across REM sleep behaviour disorder or disturbance, RBD. Now REM sleep is dream sleep, and normally during dream sleep we become atonic, we go floppy, and these patients though don't become atonic. They act out their dreams, so they thrash about and they can actually do purposeful things. The partner can find their spouse with their hands round their neck but completely asleep. So now you might think that's dangerous, but they can be woken up from it, usually fairly easily, and so it's thought that it's not a defence in a court of law. I don't think that's been tested in Parkinson's disease yet. But an interesting aside, for most people with this condition, the key problem is just keeping their partner awake. And sometimes they end up not just in different beds, but in different rooms. So, yes, so if they start to report that they're thrashing around in bed and they're having to have separate beds or separate rooms, get them to flag that up, because there are things we can do about it. They're not great. Clonazepam, one of the benzodiazepines, can be quite effective for that, and modafinil. So we've got some drugs that we can try for that. And of course, if they're not sleeping very well, if it does wake the patient, then it can affect motor function. But usually the patient stays asleep. It's the carer who gets woken up. And if the carer can't sleep, then of course it's a nightmare for them because they're shattered the next day. And if they're dealing with this patient with declining motor function, declining cognitive function, it just adds one thing on top of another. And if you can just stop this, then you can make a big difference to the carer's quality of life and therefore the patient's quality of life. So, you know, it's worth knowing about all of these things. And finally, pain. As I said, a lot of pain in Parkinson's disease. It's frozen shoulders, comorbid arthropathy, it's things you might expect. But there's quite a lot of work just being done in the ProBan cohort about this, ProBan based in Glasgow, but the pain work was based in Manchester, just published, and it's quite a frequent problem. And there definitely seems to be the phenomenon of a central pain type syndrome in Parkinson's. So they have this odd burning, tingling, stabbing, aching, itching type of tension feeling. So it's a little bit like the restless legs, but it can be anywhere in the body, under-recognised, not treated things like gabapentin and pregabalin, things like that. Again, if the patient's mental state will tolerate that. Cause a lot of distress and therefore reduce quality of life, and it doesn't respond to dopaminergic therapy. A lot of these complications don't respond to us just giving them dopaminergic therapy. Quite often, actually, what we give them for their motor condition will actually make it worse. So it's really important that we get to grips with non-motor features. As I say, right at the end, for you, I think it's just a case of being aware of these really, so that you know what they are, because some of these things are pretty weird, you know, like the gambling and the eating in the middle of the night. But if you spot it and flag it up, you can make a big impact on that patient and carer's quality of life. So with that, I'll stop and take questions. Thanks very much.